Hi everyone, welcome to Pulmonology Read Aloud. We are in Sarcoidosis series. This is the part 3 video. I am Dr. Anshum, and in the channel Pulmonology Read Aloud, we discuss and read aloud guidelines and major statements in pulmonology. If you are new to my channel, press the like, subscribe button so that you know when I post another video. So let's get started. The main content of this video on the CT scan findings in pulmonary sarcoidosis has been taken from this document, which was published in European Respiratory Journal, but I have also used a lot of other resources and articles and especially images which have been taken from other research articles so that the topic is clearer. So when we do a CT scan for sarcoidosis suspect patient, one, we know that most of the CT scans that we are doing are in the high resolution CT protocol. So what high resolution CT means is that we will acquire 1 to 1.5 millimeter thin slices that will be at 10 spaced intervals. Normally in all patients with suspected sarcoidosis, you will not need a contrast scan. A contrast scan may be required when you are suspecting, for example, pulmonary hypertension, or when you want to know more about the lymphadenopathy in early sarcoid stages, or patients where you want to see the vasculature. Other than that, a non-contrast or only a high-resolution CT scan may also be done initially. Also, in some patients, there may be a lot of airway involvement in sarcoidosis. There may be some small airway involvement for which we may want to see at air trapping. And in such cases, whenever you ask for a CT scan, ask for an end expiratory scan as well. That is very important. And it also helps us distinguish a lot of other entities and differentials. So that should be added in your CT requisition. So when would we do a CT scan in a patient suspected of sarcoidosis? Now, normally when you start suspecting a patient with sarcoid, you would first want to do a chest x-ray. You will see a bulky hilum. You will see bilateral hilar prominence. Maybe also discern that it is bilateral hilar lymphadenopathy. So in all cases, would you go ahead and do a CT scan? Well, the ATS, ERS and VSOG committee does recommend a CT scan for patients with atypical findings, patients where you're not sure with just the x-ray and the clinical data. Obviously, even with a normal chest x-ray, I would go ahead and do a CT scan for a patient suspected of sarcoidosis. And it's also important because it tells us about the accompaniments, the complications, the staging of the sarcoid. So if I would suspect a patient with sarcoidosis, almost all of these patients would undergo a CT scan, and that will have a lot of implications with the diagnosis as well as management. So what are the radiological findings that we're looking for when we are performing a CT scan for suspected sarcoid? One, lymphadenopathy. So we all know that we start suspecting sarcoidosis with presence of lymphadenopathy on the x-ray, and mediastinal lymphadenopathy is one of the hallmark of early stages of sarcoidosis. So one, we would want to see for lymphadenopathy. Two, we can expect nodules. So sarcoid nodules are typical. We'll be discussing about their appearance. So sarcoid nodules or appearance of nodules would be the second thing to look out for. A lot of times you would also see nodules along with consolidations, with masses, with certain alveolar shadows, irregular shaped nodules. So that is another scenario where we could suspect sarcoid. The other thing is ground glassing, ground glass opacifications in the lung, and in complicated stages, in stages of advanced sarcoidosis, fibrosis or scarring or fibrocystic appearances may also be seen, but this is morely in the last stages of sarcoidosis. So usually when we first suspect sarcoidosis in this patient and we perform an x-ray, right at that stage, we can kind of ascertain which stage of sarcoidosis our patient is in. And most of you may be aware of this classification for revision. So in chest x-ray itself, scanning proposed a classification for the staging of sarcoidosis. And let's quickly revise what it meant, and then we can further interpret it in terms of CT scanning. So in stage 1 sarcoidosis, we see bilateral hilar adenopathy. The rest of the normal lung parenchyma will be normal. In stage 2 sarcoidosis, we see hilar lymphadenopathy, but we also see some pulmonary infiltrates. In stage 3 sarcoidosis, the lymphadenopathy goes away. So there is no lymphadenopathy here, but we do see pulmonary infiltrates only in such patients. And in stage 4 sarcoidosis, there is extensive fibrosis. So this is the fibrotic stage of sarcoidosis. So depending on these appearances, again, when we perform the CT scan in these patients, we may see different manifestations as discussed in the previous slide. Let's start with thoracic lymphadenopathy or mediastinal lymphadenopathy. Now we know that CT scan is more effective in diagnosing enlarged lymph nodes. So there is a lot of sensitivity to HRCT or CT scanning as such for diagnosing lymphadenopathy in sarcoidosis. Now the prevalence of hilar or mediastinal lymphadenopathy in a patient with sarcoidosis is around 47 to 94%. And why we have this broad range is basically because almost in all stage 1 you will have lymphadenopathy, but as we go towards stage 4 you may have less. So still on an average almost half of the patients of sarcoidosis will have lymphadenopathy when you perform their CT scan, and it goes higher in the earlier stages, and mostly lymphadenopathy is bilateral. So bilateral lymphadenopathy with right sided predominance is one of the most common manifestation presentation of sarcoidosis. Let's look at the other lymph node stations involved and uh, what is the order of occurrence. So according to the ERJ paper, the most common frequency of lymph node involvement is the right lower paratracheal lymph nodes. So the 4R lymph nodes. So the 4R lymph nodes, the lower paratracheal, are most involved. This is followed by 10R lymph nodes or the right hilar lymph nodes. The right hilar are followed by the subcarinal lymph nodes or the station 7 lymph nodes. This is followed by the subaortic lymph nodes or the aortopulmonary window lymph nodes, and this is followed by the 11R lymph nodes, so those which are left interlobum. So most commonly when we perform an endobronchial ultrasound, we're able to sample the 4R and the 7 stations with ease, and once we go ahead and sample the 11 or 10 lymph nodes, we can have more diagnosis, but 4R and 7 usually clinch the diagnosis in a lot of patients. Sometimes we can also see that different stations may be involved, and then we may judge the lymph node involvement on the CT scan by seeing a median of the sizes of the enlarged lymph node. We can have calcification in lymph nodes. It is typically described in sarcoidosis as calcified, non-necrotic lymph nodes, but it is not always the case. Also, you may also have a unilateral or localized lymphadenopathy. You may not always have bilateral lymphadenopathy, and sometimes you may also have effects because of these enlarged lymph nodes on the adjacent organs. You may have effects of these lymph nodes causing compression symptoms, stenosis. So that is also a common occurrence. Coming to the other common manifestation, which is nodules in sarcoid. So now when we talk about nodules in sarcoid or sarcoid nodules, they're actually equivalent to the granulomas that you see on pathology. Now where are they located? It's very important to remember that the nodules in sarcoidosis are located in the upper or the mid and posterior part of the lungs predominantly, and they are also more abundant in the subpleural regions and the peribronchovascular regions. So always remember that sarcoid nodules will follow the peribronchovascular region, and they would be more in the upper part of the lung and the posterior parts. So nodules will be seen almost in all patients of sarcoidosis at some point of time. 80 to 100% patients present with nodules. They have a perilymphatic distribution around along the peribronchovascular bundles, and they are also seen more, as I said, subpleurally. So they you can see them along the chest wall, you can see them along the mediastinum, and definitely along the fissures also. These are small nodules. So why this is very important is because then you can distinguish between the various differentials. So these are less than 10 mm, and they are irregular nodules. They don't have very well circumscribed margins, and you can see them easily in the bronchovascular sheath and in the septa. So this is an image of a CT scan in a patient with sarcoidosis. Let's see this example. You can see these tiny nodules. They are not very big. You can see that these nodules are easily seen along the fissures. They are also seen along the interlobular septa. They are discrete. They are not very well defined. They are not like punch nodules. They don't have very good circumscribed margins. And these are discretely located and distributed. And a lot of times these nodules are subpleural in region, they may be along the mediastinal structures, and these may be distributed mostly but along the, as you will see in this image, you will see a beaded appearance. So they may be seen along the peribronchovascular region. Again, here you can see the subpleural nodules, the beaded string appearance along the peribronchovascular region, and the septa and the fissure. So in this case, along this fissure. So if you talk about the appearance of these nodules again, so as I said, they are beaded, bronchovascular or fissural. This is virtually almost always diagnostic of sarcoidosis. A lot of case reports, case studies have talked about it, but obviously there's no formal validation to it, but it is very, very highly diagnostic, and it causes an irregularity or thickening of the bronchovascular bundles. And this peribronchovascular thickening starts in the hilar region, and then actually it goes on, and it can also cause luminal stenosis many a times. Let's look at this CT scan of lymphangitis carcinomatosis and this CT scan of sarcoidosis, and you can actually note a difference right at the first go. Now what we can easily see is that sarcoid nodules are more consolidated at a point, at a region. So here around the posterior parts of the lung they are more, right? And um, the nodules in other differentials, so like in this time we are taking lymphangitis, they are these are more widespread. They are dispersed throughout the lungs. They don't have any topographic predilection as such, right? And exceptionally, sometimes because of hematogenous spread, you may see them all through the lung, or in a centrilobular configuration. But here, the sarcoid nodules are more restricted to a pattern, to a area in the lung. They will be along the lymphatics, but those nodules which are because of other differentials may be more smaller, they may be micronodules, or they may be dispersed anywhere and everywhere, as against sarcoid. So in nodular opacities, we must remember that sometimes these nodular opacities may also be accompanied by another pattern, which will be alveolar opacities. So we may have both nodular and alveolar opacities, which is like the scadding stage 3 of sarcoid. So what will happen then? So in that case, we'll have small nodules. These small nodules can coalesce. We can have huge large masses also, and we sometimes may have masses which cavitate as well. And sometimes the nodules may come together, and we may see alveolar or pseudoalveolar consolidations. This may occur in less than half of the patients, although we don't see too many large masses in sarcoidosis. And whenever you see such consolidations, they are ill-defined. They don't have a very sharp contour. They are ill-defined. They may then fade into another nodular pattern towards the surrounding lung. So there may be a lot of nodules, and in between you may have an irregular, heterogeneous or homogeneous appearance of a consolidation. Again, just like sarcoid, you expect them in the upper parts of the lung, in the upper lobes or the middle lobes. You expect them along the bronchovascular bundles. You expect them along the subpleural region. And sometimes you may also see an air bronchogram sign here, and it may confuse with bronchiolitis obliterans. So that in that case, that forms a strong differential. Let's look at how that looks. So here you can see, so there are tiny nodules, but again there are subpleural, rather a grouping of these nodules into this irregular consolidation or mass-like structure. But you can see there's a lot of structural distortion here, and again in this region you see a lot of nodules and in the peribronchoscopy region a consolidation, and this time this consolidation also has an air bronchogram. So this is not a consolidation, actually you're seeing this with a nodule, you're seeing it bilaterally, you're seeing it in the upper lobe, you're seeing it subpleurally. So this is more in favor of sarcoidosis as compared to a pneumonia for that instance. And bronchiolitis obliterans organizing pneumonias can also be confused sometimes with this appearance. Let's look at other patterns of nodules and alveolar opacities. Sometimes you may get necrotizing sarcoid granulomatosis. Now, this essentially means that there is a sarcoid granuloma and there is non-caseating necrosis going on, and it also involves the vasculitis. So, it involves arteries and veins. You may think of it as something like an invasive aspergillosis, or the appearance may look like a cavitating pneumonia, but here you can see these are multiple. You see their bronchogram, you see this kind of cavitation or necrosis going on in between, and on histopath it turned out to be necrotizing sarcoid granulomatosis. Cavities are another presentation, usually in the fibrocystic stage of sarcoidosis, in stage 4 advanced sarcoidosis, and sometimes you may think of you may complicate it with tuberculosis in advanced TB as well, but not very common. But yes, they can occur again in the upper lobe, so again it confuses with TB. And why it happens is because there is necrosis. So there may be ischemic necrosis and all the hyaline material comes out of the granuloma, so the cavity becomes empty. And how common is it? Almost 3% or 3 to 6% in various studies. And you may get them as thin walled cavities in a lot of cases, but sometimes when there is an infection going on, there will be a thick walled cavity also. They may not be this huge in size though, they may be variable. Sometimes they may be present isolatedly, sometimes they may be bilateral, multiple, and usually more severe and more advanced and active sarcoidosis will have more cavities. Primarily just having a cavitatory sarcoidosis is not very common, right? But whenever we see this appearance, another strong differential that comes to mind is Wegener's or granulomatosis with polyangiitis and some infection. So that also becomes a strong differential in such cases. Let's come to a few signs that have been described in sarcoidosis when we talk about nodules. So this is the first sign. It's called sarcoid galaxy sign. Now, if you think of galaxy, just the word, you can think of something like a solar system. So just think about it that way, that there's something in the middle and there are tiny things around it, right? So these are usually large nodules. They may be multiple in the lungs, and they don't have a regular well-defined boundary but an irregular boundary, and there is a rim of satellite nodules around it. So a center, a large nodule with a rim of small nodules around it. And actually if you see it pathologically, then it is lot of granulomas that have coalesced together and have concentrated. In contrast, we can also see sarcoid cluster sign, and in sarcoid cluster sign you may have these rounded long clusters of many nodules. But have they coalesced together? They have not. They are not confluent. There are many nodules which are together, so they are looking like small clusters. So these are granulomas, but they don't have any coalescence. So these two signs have been reported. Initially some reports mentioned them as specific of sarcoidosis, but they are not specific. You can see them in other granulomatous diseases. Sometimes TB may also look like this, silicosis, cryptococcosis, but it is a good sign to elicit, to see on the CT scan, and it may lead you towards sarcoid diagnosis. The next pattern on a CT scan includes reticular pattern or linear opacities. And when we talk about linear opacities and reticular pattern, we think of interstitial lung disease. So in sarcoidosis and sarcoid-induced ILD, in the stage 3 sarcoidosis, for instance, you may see a lot of thickened nodular interlobular septae or septal lines which are more prominent. And this can be seen between 25 to 89% patients. These are not as prominent than the nodules. Nodules are usually more commonly seen in active sarcoid. This is more in stage 4 or late disease or fibrotic disease. They are also irregular, they are distorted, and sometimes they can then again coalesce, and you see these irregular or polygonal or reticular network, and sometimes they may be superimposed with ground glassing also. So here you can see these linear opacities, these bands which are irregular, they are causing structural distortion, and they can also coalesce at areas. And let's compare it with another differential. So again, let's compare it with lymphangitis carcinomatosis here. You see this is more extensive in one area. It is asymmetric, and there is a lot of involvement of interlobular septa here, but there is no architectural distortion of the lung. So it's limited to this area. We can see a lot of involvement here, but the rest of the lung, there is no architectural distortion around it. So scarring and fibrosis will always involve displacement of structures of hyla or fissures. There'll be distortion, and sometimes you may see the bronchus displaced. You may see volume loss in the upper lobe. Again, confuses with TB, but fibrotic sarcoid may have that. You may have bronchial stenosis, deformity, angulations, and it's very common in stage 4, as I said. So let's look at these images. The X-ray speaks of extensive parenchymal infiltrates. This is the corresponding CT scan. Here you can see large conglomerate masses which have conglomerated out of the nodules. Here there's a lot of structural distortion, a lot of pulling of the mediastinal structures, and when you see a volume rendering image of the bronchi, you see that the bronchial stenosis is occurring because of this distortion at several places. So conglomerate masses, posterior location, superior upper lobe, middle lobe involvement, and with distorted, not TB, and also bronchial stenosis. This is sarcoidosis. When we speak about reticular opacities, we also see them sometimes along with ground glassing. So ground glassing can be seen again in a huge majority of patients, up to 83% patients. And why ground glassing occurs is because multiple micronodular granulomas can coalesce, and you may see that area as a ground glass. It's also very common in the initial phases on presentation of the disease. You may see multifocal areas of ground glassing, and again superior predominance, upper middle lobe predominance, no margins whatsoever, no well defined margins, and you may see a subtle nodularity, and you may see lymph nodes. Now sometimes it may confuse us with HP, chronic HP, and so an expiratory scan can be done. We can see whether there's evidence of air trapping or not, and this ground glassing will be suspicious of sarcoidosis. You see it's subpleural, you see there's architectural distortion around it and in the upper lobe. So again, suspected sarcoid. One thing that comes out of all these slides is that definitely when we talk about various manifestations of sarcoidosis, whether it's reticular opacities, whether it's the structural distortion, traction and bronchiectasis, whether it's the late advanced stage and causes honeycombing, or it causes cystic destruction, bullae, cavity, or the pulling causes emphysema because of the cicatrization, it's mainly in the middle and the upper areas. So that is how we can actually distinguish it from UIP or IPF, because it's more in the middle and the upper lobe of the lung and not in the lower lobes of the lung. So talking about UIP, IPF and advanced sarcoidosis, it's a good time to talk about the patterns that we see in very advanced sarcoidosis, which is in stage 4. You see a lot of bronchial distortion. You may see honeycombing also. You may see linear patterns. Initially, what is visible as ground glassing, if you keep doing serial X-ray, CT scans, you may see that it's gradually progressing and evolving into honeycombing. And again, upper and perihilar. That's something that has to be remembered and noted. What are the other ways it can involve the lung? You can see airway involvement on a CT scan. It may be in the form of central or distal obstruction. We've already seen an image how bronchial stenosis can occur. So there may be mural thickening, wall thickening, luminal narrowing, and stenosis, and this can be visible on CT scan images along with air trapping also. Here you can see the stenosis arising in a case of sarcoidosis. Here also you can see the bronchial wall destruction and the stenosis arising secondary to sarcoid. Is pleural involvement common? It's not very common. It is rare. There are definitely, however, case reports which have been published about pleural effusion in sarcoidosis. And when it does occur, it occurs because of the pleural granulomatous involvement or because of lymphatic blockage because of the granulomas. So it's not very common, but it can be seen. It is reported. And pneumothorax can also be seen when there are huge bullae where there's a lot of destruction, especially in stage 4 sarcoid or because of a rupture of a cavitary lesion. Coming to some more signs, these three are commonly described signs in association with sarcoidosis. Again, may not occur exclusively in sarcoidosis, such as the halo sign, but they have been frequently associated. So let's talk about them. The first one is the halo sign. A halo is like a ring which surrounds a solid structure, just like the halo in the fairies. So, a halo sign talks about a ground glass opacity surrounding a nodule. So, there is a nodule and there'll be a ground glass surrounding the nodule. That's called halo sign. There's another sign called reverse halo sign. We just reverse this process. So, there will be a ground glass in middle and it will be surrounded by a ring of consolidation. So ground glass and then some consolidation around it, reverse halo sign, and a fairy ring sign. Now this has been only described in a case report, and it has been reported in that case report, not very common, but what it does signify is that there is a halo and there is a nodular border because of the granulomas. And why it differs from reverse halo is because the central part of the lung is normal lung. So here there's ground glassing and then consolidation. Here the central part is normal and then you have a nodular shadow. So that is fairy ring sign. Now halo sign, there are lot of causes, lot of differentials like infections, neoplastic causes, especially invasive aspergillosis is a very strong differential, and it really means that there are intraalveolar granulomas and aggregates and surrounding area you can see the ground glassing. The reverse halo sign, as I said, it's although it was long regarded as highly specific of organizing pneumonia, the et al. Sign, but this sign has also been cited in sarcoidosis, so it can be seen here as well, right? And if you see nodular walls or nodules inside the halo in these reverse halo sign, you can demonstrate the nodules with the reverse halo, then it's very suggestive of a granulomatous disease. So what is the role of CT scan altogether now in sarcoid diagnosis? If you just talk about clinical data, you'll be able to diagnose less than half of sarcoid patients. When you combine it with X-ray, you get around a 75-76% of strong probability of sarcoid diagnosis, and that increases marginally with CT scan to 80%. So one can argue that even an X-ray gives us a very good indication of sarcoid. Why would we need an HRCT? That's because an HRCT helps you follow the patient better, diagnose better, pinpoint the sites for diagnostic testing, biopsies, lavage, and so a CT scan has a very important role to play in sarcoidosis. Also, it's to be remembered that there are certain features in a sarcoid CT scan that are reversible. So you may see micronodules which are not visible in frequent scans later. The peribronchovascular thickening can disappear as the stage of sarcoidosis changes. But what's irreversible is the architectural distortion, honeycombing, and bullae. Variably, the consolidations can improve on treatment, the ground glassing can improve, and the linear opacities can improve. So, that is very important. And when you see a response to therapy, the bronchial distortion will not improve on therapy, but the peribronchovascular thickening, the compression, and the air trapping can improve on treatment. Sometimes CT scan also helps us diagnose the complications of sarcoidosis, and in that, pulmonary hypertension is a very common accompaniment. So, whenever pulmonary hypertension is seen in a case of sarcoid or suspected sarcoid with pulmonary hypertension, again, this adds a lot of diagnostic value. So let's conclude that there are few things that are very common in sarcoidosis on a CT scan. When you see a bilateral hilar lymphadenopathy and a perilymphatic micronodular involvement, that's virtually almost always diagnostic of sarcoid. The extent of parenchymal disease involvement, the reticular opacities, the ground glassing, they all are important to ascertain what likelihood would be that we will get the diagnosis on testing. So when we're planning TBLB, we're planning endobronchial ultrasound guided needle aspiration, the CT scan plays a very, very important role. So this is all from Pulmonology Read Aloud today. I hope you enjoyed this session. I will be adding the links of the first two videos of the series on sarcoidosis, and we conclude the series here. Thank you. Happy reading. Do like, subscribe, and share this video. Bye bye.